So when it comes to renal tubular acidosis, there's a few clinically relevant points here, both clinically applicable and clinically examined. So the focus is on what kind of metabolic changes are occurring in the body while there is this renal tubular acidosis. Now there's type 1, type 2, and type 4. Type 1, the issue is actually primarily in the distal tubules. And for type 2, it's in the proximal tubules. And then finally, type 4, it's kind of more so with the adrenal glands and in the adrenal area. By the way, here it's acidosis mild. That's if even present. Now, what we need to be aware of is that type 1 renal tubular acidosis does result in hypokalemia. So this results in hypokalemia, and so does type 2. However, type 4 results in hyperkalemia. And we'll explore why that is, but that's one of the most high yield examined concept. So what's happening? Let's get detailed. Type 1, there is hydrogen retention. And in cases of hydrogen retention, of course, this is going to mean acidosis. So, yep, it's going to mean acidosis. And why is there hydrogen retention? It's because there's a failure of hydrogen ion excretion, okay? And this is type 1 RTA. And then this presents with hypokalemia. Then, for type 2, this is due to failure of bicarb reabsorption. And remember, bicarb is a substance, is a compound that actually helps with making the conditions more alkaline. And if there is no bicarb, you, by definition, will then get acidosis. So once again, this is acidosis. But here in type 4, you have a deficiency of aldosterone, and aldosterone is a hormone that acts for the reabsorption to increase the bodily sodium. Okay, sodium plus. So aldosterone acts for the reabsorption of sodium. And remember the renin-angiotensin-aldosterone system. Whenever there is a detection, renin-angiotensin-aldosterone system, whenever there is a detection of low blood pressure, then the RAAS system kicks in, and in that case, it activates aldosterone to then go and reabsorb sodium. Wherever sodium goes, water follows, and then by that mechanism, it can raise the blood volume and the blood pressure. So, what's happening? That's one thing that aldosterone is responsible for. But while simultaneously reabsorbing sodium, aldosterone is excreting out potassium. So, the normal functioning of aldosterone is to reabsorb sodium and in exchange excrete out potassium. And in that instance, if there is a deficiency, so what's going to happen is either there's going to be a deficiency of aldosterone or there's going to be resistance. So either a deficiency or resistance. And if there's resistance to aldosterone or a deficiency of aldosterone, you are no longer absorbing sodium. That's going to lead to you're no longer reabsorbing, okay? Reabsorbing. That's going to lead to hyponatremia, and you are no longer excreting potassium. That means you inside this is the body, and pretend before you were excreting out potassium in exchange for keeping sodium. But now you're not keeping sodium, so potassium cannot be exchanged. This works like a business partnership. You give something and you lose something. You give something in exchange for something else. So then that follows that potassium in the body rises, causing hyperkalemia. And you need to remember all of your clinical consequences of having hyperkalemia, but primarily remember that the most dangerous is arrhythmia. We're always associating, when we have our clinician hat on, we're always associating hyperkalemia hyper kalemia, we're also always associating a high level of potassium with cardiotoxic arrhythmic properties. And when it can cause an arrhythmia, this can be fatal. So you need to always be aware. And remember that if you're controlling the hyperkalemia, you can use fludrocortisone, furosemide, and resonium in the case of type 4 RTA. And here you're not really affecting the acidosis levels much, are you? So if you're not affecting the acidosis levels so much, you don't have to give anything to treat the acidosis in type 4. But in type 1s and type 2s, there is acidosis and substantial acidosis. So here we are going to have to administer treatment with sodium bicarb oral or high doses of sodium bicarb or IV, oral or IV, depending on how severe it is in the patient. Okay, so thanks for listening.